leave in your busy schedule. I'm very thankful for you to taking out time in your busy schedule, sir.
Good.
We can start, sir.
Um, so,
Yeah, you're audible. Kindly start.
thanks. Ventilator pressure dysynchrony or asynchrony. There are certain things which might I little complicated, but we'll try to go through it together. So, what is a ventilator pressure dysynchrony means? Anything is which is happening between the ventilator and patient which is not proper or which is not synced. It is called as asynchrony. It might be related to a lot of things. It might be related to the patient effect, might be related to the ventilator effect, might be related to the flow, cycling, trigger, respiratory drive, all those things, or a patient respiratory drive, neural drive. So when they are not synced with the ventilator, then you will have asynchrony. Asynchrony doesn't mean every time it is really bad. Sometimes it is acceptable, manageable, but almost one third of the time it causes a lot of trouble. And what trouble it causes, let's see. So it is kind of a mismatch between need of a patient and assistance from the ventilator. So how is this? Yes, at any point of time when you ventilate any child, almost one third of the duration of ventilation they'll have asynchrony. And asynchrony is really bad. Why? Because it's associated with longer duration of ventilation, increases mortality, increases usage of sleep disturbances because of causes increased use of a neuromuscular blockage. So if we manage the ventilator or probably set up the ventilator nicely, we will be able to help the patient with a lot of different variables. So same thing, if you see this article in PCCM, 33% of the time when they analyze the breath, the patient has an asynchrony. And what, as we discussed, increased workup, it can cause increased workup breathing, more sedation, confusion, higher mortality rate, pneumothorax, air injury, okay, and ventilatory induced lung injury. So, what is that? This is basically, one minute. So, what is there is patient ventilator interaction. Patient ventilator interactions are really important when you have a patient, I would say, derivatives, which are really kind of important when you are putting this patient on ventilator. Ventilatory demand, what is the disease? Is it a resistive disease or compliance disease, lung volumes, all those things. And at the same point of time, you have a ventilator where there are a lot of different variables. You have mode of ventilator, what type of ventilator you're using, conventional, high frequency, what tidal volume you're setting, what is a trigger. All those things are really important when you think about patient and ventilator interaction. And if any problem arises because of this interaction, you might have some symptoms, sign, or you have to look at the ventilator to identify this kind of a ventilatory pressure dysynchrony. So what are the patient factors? Again, sedation, you know that if the patient is not properly sedated, if the patient is not properly sedated or it is, let it be overly sedated, both of things are really uncomfortable. But if you have a asynchrony, you might have to use a lot of sedation. Then there is something called as a neural timing. So there is a timing of an inspiration and expiration, which is kind of a setup inside the brain. So there is a still possibility my brain feels that I should initiate the breathing, but my diaphragm is lagging, and because of that, ventilator is lagging. So this is called as a neural timing. What kind of disease we are dealing with, compliance or respiration, what is in auto peep, which is also helpful to understand the mechanism of asynchrony. 1 minute. important when we are talking patient and ventilator dysynchrony. Size of the airway also, because we know that if the size of the tube is too big or too small, so there will be a lot of leak around the tube, which might cause a trouble, as I said, leak. So all those things are responsible for a lot of patient factors which causes asynchrony. What about ventilator? Again, don't feel it is too much. We will talk about it. Trigger variables, esophageal pressure, diaphragmatic pressure, sensitivity settings. We'll go about each and everything. Rise time, mode, flow delivery system. All those things are responsible for a lot of asynchrony if it is not done properly. Flow pattern selected, exhalation valve design, how positive and expiratory pressure is generated, all those things, as well as other things which we do, like use of a nebulizer, which kind of a nebulizer we are using. So, generally speaking, this is most important slide. When we talk about ventilator asynchrony, they are related to trigger. It could be ineffective, auto trigger, double trigger, or reverse trigger. We'll talk about it each other. Cycling, it could be a premature cycling or delayed cycling, which can cause an asynchrony, flow mismatch, and peep asynchrony. So we are going to talk about all those things together. So look at this diagram. So if you see this diagram, so there is a trigger asynchrony. So what is happening is a pressure waveform or a pressure scalar. What happens is this is a peak. How ventilator come to know that I should initiate the breathing is if I put a trigger of a pressure. So, or a trigger as a pressure. That means, let's assume this PEEP is 6. And if I put a trigger sensitivity as -1, that means once patient initiate the breathing, which is a negative pressure breathing, so what will happen? If the patient initiate the breathe sufficient enough to drop this PWP from 6 to 5, then ventilator will feel, oh, patient is breathing and ventilator will deliver the breath. So you can have a problem related to this, which can be auto triggering, ineffective effort, delayed triggering. That means it is possible if I put a trigger, let it be -5. That means if my positive and expiratory pressure drops from 6 to 1, then only ventilator will come to know, which is really a very uncomfortable thing from patient point of view. He has to take a really big breath to do that. So that is called as a trigger asynchrony. Then you have a flow asynchrony. So here you see the flow matches with the pressure waveform. But if the flow is delivered in a very short span of a time and delivered in excess, so what is happening is it should not cross the pressure waveform. And you can see this is going beyond it and it's falling and then it's stabilizing. So excessive flow, you can have an asynchrony, insufficient flow. So it doesn't reaches the way it should reach to keep the lung inflated. So there is a kind of a difference between the patient what you call inspiratory time and the ventilator inspiratory time. You can say like that. So there is an insufficient flow. Then you have a cycling asynchrony. What happens is here the inspiratory valve closes and the expiratory valve opens. But if it doesn't open in time, this is a delayed cycling. It is taking a little bit of time for the expiratory valve to open and start the cycling. So this is called as a delayed cycling. Or you can have a condition where what is happening is there is a subsequent slow fall in the pressure. But what has happened is there is a early expiration is stopped and the expiratory valve is open. Inspiration is stalled and expiratory valve is open. So you can have a premature cycling. So what trigger we put it on the ventilator? If you know routine ventilator, what we do is we put pressure trigger and flow trigger. So what happens in a pressure trigger? There is no gas flow. And what happens is we have to bring down the pressure to the trigger value. So like as I told you, -2, that means if the PEEP is 6, the pressure has to fall down to 4 to start the breathing. And here the work of breathing is more because patient has to really take a deep breath to get it down. Flow, there is a gas flow present. So what happens is if there's just imagine if I put a flow trigger of 1 liter. So it is easy to bring down that flow from just imagine 10 liters to 1 liter because that the flow is there into the system. So there is a shorter delay time, it is more sensitive, and there is a less work of breathing. So trigger synchrony, we'll talk about it: ineffective trigger, auto trigger, double trigger, reverse, and delayed trigger. So ineffective triggering, what has happened is, so again, triggering means that the ventilator is not in a sync with the patient and it is not identifying the patient negative deflection pressure so that ventilator should help, or a negative flow pattern so that the ventilator should help. So what could be the etiology? Insensitive trigger setting. That means we have kept the settings too bad. So example, if the patient is, just imagine mounting an effort of -1, and if I keep a trigger of -5, that means I have kept the very insensitive. There is no way patient is going to bring down the pressure by less than a 5. So that means I'm doing an insensitive trigger. Respiratory muscle weakness, again, they will not able to mount because they will breathe a little bit, but we will not able to come because there is a muscle weakness. Diminished respiratory drive is there. Again, they will not actually mount and trigger. Dynamic hyperinflation. What happens in a dynamic hyperinflation? There is an auto peep. And what happens is auto peep will, so even if I put a P, there is a peep of 6. And if I put a trigger of -2, so it has to come down to from 6 to 4 to trigger the ventilator, but already I have an auto peep of 10. So it is not possible to bring down it to the 4. And all combination of this. So this is an ineffective trigger. What is happening is, again, you can see flow pattern. So inspiration and then you have an expiration. And what happens is there is a positive deflection. That means patient is taking a breath, which is shown as a negative deflection in the pressure waveform because the patient is trying to drop the peak because it is taking a breath in. And what is happening is ventilator is not recognizing this and it will keep on happening. And what happens is it will increase the work of breathing. Same thing over here, negative deflection because I kept it very, very low. I kept the triggers very low. That means I am not letting the ventilator to know whether the patient should breathe or not. So ineffective trigger can happen during the expiration as well as inspiration. You see in flow pattern, what is happening is if my neural timing is not in sync with the ventilator, what happens is there is an inspiration and suddenly patient is taking a breath. This could be because of the flow starvation. This could be because of the sedation related issues. This could be because of the secretions, or patient is having a little bit of a cough. So all those things. So you have an ineffective triggering during inspiration as well as during the initiation of a breath. Again, ineffective efforts. Same thing. What is happening is you can see both during the inspiration and expiration, there is a lot of line down. This could be because patient is kept on breathing over it. Now, what happens to the PV loop? So what happens is in a PV loop, just imagine most of the time, let it be if you put a trigger sensitivity of -1, -2. So once the pressure drops down to that, then what happens is ventilator will trigger and then the expiration will happen. Then again, the breathing will start from this. But if I keep it too much negative trigger, that means I am asking patient to take a very, very deep breath to trigger. So again, I'm coming to the same concept again and again. Just imagine my PEEP is 7. And if I keep a trigger sensitivity of -2, so what will happen is I have to breathe in to drop down the pressure or PEEP from 7 to 5, then only ventilator will come to know whether I should deliver a breath or not. But if I keep that trigger sensitivity -5, so now I have to initiate so much of effort so that I drop down the PEEP of 7 to 2 because I kept it -5. So what will happen is I will have keep on having more and more negative deflection and then I will have a breathing. So this is called as a fishtail, which suggests that I'm increasing the work of breathing. I'm asking the patient to breathe in too much and I'm making the ventilator insensitive about it. But if you correct it properly, if you make it from -5 to -1, what will happen? The moment there is a drop in the pressure from 7 to 6, ventilator will deliver and it will be able to help them. Now, auto triggering, again, commonly seen in the ventilator, there is an increase in the flow, volume, and pressure without any sign of a patient effort. So there is a out of sync present frequency in ventilator. So ventilator and patient are not kind of a sync at all. This can be because of the leak, because ventilator will pursue leak as there is a drop in the pressure. And who can drop in the pressure in the ventilator pressure interaction? Only patient can bring down the pressure because at any point of time, there is a positive pressure in the ventilator. If it is becoming negative, what ventilator feels it is because of the patient. And if it is because of the leak, still the ventilator will say it is because of the patient. And it will deliver the breath. So improper sensitivity, I am keeping it too sensitive. That means, example, if I'm keeping the pressure trigger of -0.5 or I'm keeping a 1 liter flow trigger. What will happen is it is very sensitive. So what is happening, even if there is a cardiac activity or little bit of an activity, what will happen? Ventilator will feel, oh, patient is breathing and it will deliver. So it is making too sensitive. Condensation in this cardiac oscillation as we discussed. So what is happening here is auto triggering. Because of the small changes or a leak into the system, there will be a drop in the pressure and ventilator will feel, oh, patient is breathing and it will keep on giving breath. So this is called as auto triggering. Again, same thing, or there is a peritubal leak, anything. Same thing. These are all because of the oscillations. So you have made the ventilator very sensitive, and these are all in between getting supported by the proper building. Double trigger. So very good concept. Two consecutive ventilatory cycles separated by a short expiratory time. So there are two breathing pattern. There is a short expiratory time, half of the inspiratory time or less. So basically it is less than the half of the inspiratory time, but there is a sufficient expiratory time, and of which the first has to be patient or ventilatory triggered. Okay, so that means what is happening is a ventilator is triggering 2 times, and two of the breaths are separated by a very short expiratory time, which is probably half of the inspiratory time. So double trigger when it happens when the respiratory drive is too high because patient wants it and we are not able to deliver that and the patient keep on breathing over it. So if you are giving an insufficient support, which usually happen, and this is really important, the patient TI is more and the ventilator TI is less. What will happen is the patient TI is more, ventilator TI is less. Then what will happen is ventilator will keep on delivering the breath because it is not matching with the patient. So what is happening over here is you can see. So you have this flow pattern. You can put a pressure pattern again came down, and then what happened is there is a small breathing, there is a negative deflection, and again there is a breathing. So what is happening is the ventilator is triggering 2 times. This is actually probably given by the ventilator without any patient interaction, and then here patient breathe in, bring down the pressure, and then the ventilator get triggered. This is called as a double triggering. Same thing, double triggering can happen during the inspiration also because there is no match between the ventilatory TI and patient TI. So again, here you can see these are the efforts probably which are not recognized, but there is a little bit of more effort. Again, drop in the pressure. Then it is not recognized. Again, drop in the pressure and the ventilator recognizes to give it. And again, here also during the inspiration, there is a drop in the pressure. So there is a complete discrepancy between the patient TI and the ventilator TI. So same thing you can see. So there is a breath. Again, what has happened is this is basically supported breath. This is a ventilator breath because you see there is a red pinkish mark. So you have the patient breath and then, sorry, ventilator breath, and then again drop in the pressure triggered by the ventilator, and then you have a proper breath. So this is basically double triggering. You keep on triggering, and both of them are separated by there is an expiratory time which is less than the half of the inspiratory time. Same thing. Now reverse triggering. So what happens is in the heavily sedated patient, what happens is there is a difference between kind of a neural TI and the patient TI and the respiratory TI of the ventilator. So because of that, so fixed repetitive temporal relationship between the neural and mechanical respiratory cycle, that causes a trouble seen in heavily sedated patients. Diaphragmatic muscle contraction is triggered by the ventilator on initiation, which is there. So you have a diaphragmatic sometimes it is stimulated by the ventilator also. And because of the deep sedation, you don't have a cortical influence on the respiratory valve. So both works in a different direction. So what is happening is, again, here you have, you can see like that, there is a breath delivered, expiration. And then what happens over here is, there is a decrease in the pressure or pressure drop. So why the pressure drop happens is heavily, there is some muscle contract, not able to match the patient neural drive. So in the brain of a patient, it is like that you have to initiate the breath. Though the ventilator has given a breath, so what will happen is there is a drop in the pressure and the ventilator will deliver a flow. But it is insufficient, and sometimes it can be sufficient. It can happen in the inspiratory flow also. There could be a sudden drop of the inspiration, and then again you can have an inspiration. So this is called as a reverse triggering. Again, here you can have in the inspiration, okay, Here there is a drop in the flow. Again, you have an increase in the flow. And what you can see in the pressure waveform, again, same thing, drop, little bit separated, and again. So this is all because of the heavy sedation, all those kind of stuff will be there. Now, delay triggering, what happens is, here there is a, you can see pressure waveform, the ventilator. So you have a start of an inspiratory effort. So here inspiratory effort started. There is a drop in the pressure. Then ventilator will realize, here the ventilator is realizing, and then ventilator is delivering a flow which is maintaining the I time. So there is a significant delay between the initiation of the breath and the delivery of the breath. This is called as a trigger delay. So what happens is the response time of the ventilator is between 0 to 117 seconds, milliseconds. Response between 118 to 230 was defined as a trigger delay. So you can see, if ventilator delivers the breath immediately after that, then we could say there is a less inspiratory delayed trigger, but there is a significant. And if it is crossing more than 118 millisecond, that means it is definitely delay. And if it is more than 234 milliseconds, this considered as an ineffective trigger. Now, flow asynchrony, flow mismatch, again, every patient in the condition, they have a different flow requirement. Sometimes we are not able to meet the patient's flow patterns because ventilator is not giving that much of the flow, which can happen in a lot of ARDS patient, and it causes flow starvation and increase in the work of breathing. So you have this normal pressure waveform, but what happens in the, you have a flow starvation, because during the positive pressure also, or positive pressure or positive flow getting delivered, patient is having such a high respiratory drive, it's sucking air, and that's why it becomes concave. So there is a significant sucking of air, because the whatever the flow is delivered, it is not been sufficient to take the drive of the patient. And again, here also during the inspiration, what happens? The patient is taking a breath in. So ventilator is delivering some air, but this air is not enough to keep the airway open, or patient requires more. So patient will try to breathe in more air, which is called the concave deflection. So you can see over here, what has happened is the flow is delivered, but it is not reaching to the peak, or it is not giving a proper I time. So what? Because patient kept on breathing over this pressure rise. So same thing, patient kept on breathing, and sometimes in the flow pattern you can see they're breathing additionally. It should not go up, yes, because it is set on the ventilator. So what is happening is, during this inspiratory phase, patient is breathing over it. You can see in the pressure time also, patient is breathing over it. This is called as a flow starvation. How to manage in this situation? If you have a knob on the ventilator, whether you can increase the bias flow, you can increase the flow rate, change waveform from constant to descending ramp so that it is more physiological, or sometimes you can change the mode to volume controlled or PRVC so that you have a better delivery of the volume. So you can see out over here what is happening in the pressure waveform. There is a pressure delivered, but because patient need more flow, so here you can see the flow is increased. So the patient volume is increased, patient want more flow. It is sucking more air through the ventilator, which is seen as the sharp drop and increase in the pressure waveform as like a peak. So patient is trying to draw more air from the ventilator. Flow asynchrony, excessive flow, yes, it can also give rise to and can lead to barotrauma or volley trauma. So it happens in high pressure setting where there is a lot of delivery of like ARDS, you are ventilating with a very high pressure. So here what happens is, you deliver too much of flow if the lungs are really stiff. So these things happen because there is no equilibrium of the pressure. So you can see there is a steep increase in the flow, then little bit drop because lungs are really stiff, which you can see it over here, and then it comes down, plateaus over there, then your expiration starts. So this is seen in a patient where there is a really a bad lung. Cycle asynchrony, the variable that drives the ventilator to switching from the inspiration and expiration is halted. In flow volume targeted mode, it is usually clinician will set the parameters. In a pressure targeted mode, it may be TI set by the clinician or flow cycle by the patient. Occurs when the mismatch between the neural and ventilatory TI. So what happens is, It causes an abnormal ventilatory drive or inappropriate setting. It is between brain and the ventilator. Neural TI is more than the machine TI. Then what will happen is premature cycling, as we discussed, because patient wants to breathe in before machine delivers. If the machine TI is more than the neural TI, what will happen is delayed cycling. So what will happen here is ventilator will keep on breathing, giving a breath, and in between the patient will keep on breathing. So how it will look like? Premature cycling, what is happening is where neural TI is more than the machine TI. So there is an inspiration and the expiration is happening in the flow. What happened is patient had a breath. So during expiration, what will happen? There has to be an expiration. Patient should breathe out. But what is happening in between patient breath? So there is some flow over here. As a consequence, what happens is patient effort pulls the airway pressure profile downwards and reverse respiratory flow happens, and it might cause ventilatory induced injury or breath termination, and it delivers the second breath. Delayed cycling, what has happened is machine TI is more than the neural TI. So patient will keep on breathing. So you can see it over here. There is a pressure waveform delivered by the machine. But what has happened is even it finishes before, what has happened is neural TI is stimulated. So neural TI is less than the machine TI. And what happens is there is a breath. Okay. What happens is here there is no sync between machine and the patient respiratory effort. And this is seen as an elevation of the respiratory pressure at the end of the expiration. Same thing here. What is happening is, again, cycle trigger delayed cycling is happening over here. Here, the patient should have a plateau, and then the expiration should start. But what happens at the end here, the patient neural timing sets in and it takes a breath. Same thing. Again, same thing, you can see the patient breathing coming. So there is a flow, and again the flow increases a little bit. So early cycling is here. What happened is, as we discussed it, the patient neural TI is less than the ventilatory TI. So what happens is a ventilatory induced breath. And what happens in the flow? The patient again takes a breath. So why? Even before the expiration set in, the neural TI is less, so patient will set in the breathing. You can see the ineffective efforts on the pressure waveform. Same thing over here. There is an early termination, and what happened is this is the neural kind of a mechanism of the patient, neural TI, which is set in and the patient is breathing. You can see in the expiration, there is an inspiratory effort. Same thing on the pressure waveform. Even before the breathing stops, what is happening is our breathing becomes complete. There is a TI or hold time, and then expiration, patient is breathing. So there is an ineffective respiratory effort. This is called as a delayed cycle. And you can consider this the flow star, kind of a reasonable flow starvation. Same thing. Now, auto trigger, what happens is an auto trigger is ventilator keep on breathing, keep on delivering the breath. This is all because the way, so it can be because you have set very sensitive parameters for the trigger, so that there is a small change also, ventilator will keep on seeing that the patient is breathing. And this is responsible for a lot of triggering. So what happens is in a trigger, in triggering, ineffective triggering, ventilator, what are the determining factors? Inappropriate sensitivity settings, malfunctioning of the sensitivity mechanism, prolonged inspiratory time. And what is about the patient? What we should do it in here, adjust correction of the sensitivity problem, decrease inspiratory time by adjusting setting for each mode. Patient respiratory muscle weakness might be the reason. Decrease neural drive, what do you do? Reduce or discontinue neural drive, depressant, sedation, NAVA, or you can change it to the PS level so that you can help the patient appropriately. Double triggering, you have a ventilator, inspiratory time too short to relative to the neural timing. And what happens over here is we can increase the inspiratory time, low tidal volume. So here what we can do is you can give deep sedation or muscle relaxant, reverse triggering. As we discussed, muscle effort resulting from the mechanical inflation, we can reduce the sedation and allow the patient to breathe. Auto triggering, you can see about the excessive sensitivity, leak, condensation in the ventilator, and we can do corrections while leak correction, remove condensation, and in the patient, it can be because of the oscillations from the cardiac activity, we can optimize the sensitivity setting. Cycling, you have a premature cycling. Ventilator, in that, what you can do is you can adjust the flow or increase the tidal volume. In a patient, you can do, it can happen because of the restrictive mechanism. Delayed cycling, ventilatory, because of the inspiratory time is too long relative to the patient inspiratory time. Here, it can be done by increase respiratory flow, decrease inspiratory time. Again, flow. So what happens in the flow? You have a ventilatory and patient-related issues. If you are requiring, if the flows are insufficient, what you can do? You can increase the flow or you change it to the pressure control mode. And patient, what you can do is you can think about giving a little bit of a sedation, or you think about if the patient is having hypermetabolic state or increased CO2, that's why patient is breathing more. Excessive flow, you have to really see that because there are more chances of airway injuries and pneumothoraces. So what happens is you try to optimize the setting, probably use a good amount of PEEP rather than using a higher peak pressures. Thank you.
I think Dr. Parag, because the topic is